that the protons behave like many small bar magnets, spinning like tops in phase with each other. Radio waves are pulsed into the patient by the body coil transmitter at 90 degrees to the magnetic field. Then the radio waves are chosen to have the same frequency as the spinning hydrogen protons. This energy input is thus readily absorbed by the protons, inducing them to resonate. When a radio wave ceases, the protons relax and their acquired energy is, of course, lost. The changes in energy are recorded. So transverse magnetic moment disappears in time in T2, called T2, as you remember from the first year, I hope. And longitudinal magnetic moment comes back in time T1. The largest and most important components of the MRI machine are the magnets. The magnet strength is measured in units of Tesla or sometimes in units of Gauss. Today's MRI machines have magnets with strength from half Tesla up to 7 Tesla. What types of magnets do we have? So we have a resistive, then permanent, and superconducting. So they are most commonly used nowadays. Radio waves, this is one more time to understand the examination. Radio waves are pulsed into the patient by the body coil transmitter and at 90 degrees to the magnetic field, and this is really helpful for them for their energy to resonate. And the resonation caused the magnetic moment to diminish and the transverse magnetic moment to grow. So we have a longitudinal magnetic moment and a transverse magnetic moment as well. This magnetic moment now lies transversely across the patient and is capable of inducing an electrical current in a neighboring receiver. Here we have the example, the image showing our radio waves. So here we have the field, the magnetic field, which is used to align the hydrogen protons in the body of the patient. Then we have number 2. We have a description of our radio frequency waves that are absorbed by the protons and then emitted as a signal, of course. Then a radio frequency coil picks up the signal emitted from the protons and transmits it to the computer, to our program. And the computer processes the data and image is generated and shown as our result. When radio wave ceases, the protons relax and the acquired energy is lost. As we mentioned before, we have T2 time and T1 time, so they are changing. There are differences between them in the shape of the magnetic moment. And here we have the most popular, the most basic types of images in MRI. So our T1 weighted and T2 weighted, those two are the most important. Then we have a lot of different images in MRI, used a little bit more in advanced cases. So we have a PD weighted, diffusion weighted, called DWI, perfusion image, fMRI, bold MRA, FATSAT. It's of course, especially to imaging the fat tissue, flare and steer, and many others. So you don't have to remember all of those names, I hope. Here we have a differences between T1 weighted and T2 weighted. As you can see, the fluid is one of the parts that can differentiate those images. So let's focus on a first image. So now we will talk about T1 weighted images. And the fluids have a long T1. In example, it takes a long time to re-establish their longitudinal magnetic moment, and their signal is hypotense, weak. Remember that in MRI, we are describing the intense of the signal. So we have the iso-intense signal, hypo and hyper-intense areas or signals. Then, in T1, fat behaves the opposite manner and is hyper-intense. So, the fat has a strong signal. Various different tissue, varied signals, mostly in both images, T1 and T2, our muscles are iso intense, so they are in the middle of the grayscale. T2 image. Fluids have a long T2. In example, they dephase slowly and give a strong signal. So in T2 weighted images, our fluids are strong, so are hyper intense. They are having the strong signal. Various tissue, of course, have varied signals, and the fat is hyper intense in T2 weighted images. So the fluid is the most important and the easiest way to differentiate those two basics images. This is the example of PD weighted image, a little bit more difficult to recognize and to describe. Here we have the contrast enhancement. So on the first part of the image, you will see only the beginning of the contrast going through the vessels. And here we have our veins and arteries with the contrast in it. Flare, a little bit more advanced image, especially used in MRI of the brain. Here we have a fat sat, of course. So the brain is not the best as visualized in this image, but our fat tissue is a little bit more visible. Okay, this is of course another MRI with the contrast. Here we have an angio MRI focused mostly on vessels in the brain. And one more time, to differentiate T1 and T2, you have to remember that in those images, we have high signal areas and low signal areas. So high signal will be bright and low signal will be dark. In T1, high signal is fat, melanin, blood, some kind of proteinaceous fluids, paramagnetic substances as a copper, manganese, and sometimes the gadolinium contrast used in MRI. Low signal, so hypo-intense areas. In T1, it will be iron, water, air, bone, collagen, and most tumors. In T2, the high signal will be water, so fluids itself, edema, fat, blood, most tumors. And low signal, so hypo-intense in T2 is again air, bone, chronic blood, acute blood, early subacute blood, etc. So as you can see, always in the MRI, the heart tissue as a bone, as calculus in salivary glands, as teeth. Our teeth will be low signal areas. So in those two images, our bony structures will not be visible as we wanted to. Okay. MRI contrast agents have become an indispensable part of contemporary magnetic resonance images, of course. Although MRI was initially hoped to provide a means of making definitive diagnosis without administrating contrast media, it has been found that the addition of the contrast agents in many cases improves sensitivity and or specificity. Specificity, sorry. So, in MRI, we used mostly gadolinium contrast. In computer tomography, it was based on iodine. So this is the difference between computer tomography and the contrast agent in the MRI. Okay. The gadolinium ion is useful as an MRI contrast agent because it has 7 unpaired electrons, which is the greatest number of unpaired electron spins possible for an atom. Gadolinium molecules shorten the spin lattice relaxation time, T1, of voxels in which they are present. As a result, on T1 weighted images, they have a brighter signal. This can have a number of uses. For example, detection of focal lesions, like tumors, abscess, or metastasis of the tumors of a cancer. Then, imaging of vessels in MRI, angiography, or sometimes venography. And then calculating MRI perfusion parameters. Main indication for MRI in the head and neck are assessment of intracranial lesions involving particularly the posterior cranial fossa, the pituitary and the spinal cord, and the investigation of the TMJ to show both the bony and soft tissue components of the joint, including the disc position, and the MRI is the best method, the best examination to provide the visualization of our disc. So this is the best known method. Of course, the TMJ magnetic resonance is taking place in two positions of the patient. So first part of the examination is taken with the occlusion of the teeth, patient teeth, and then we are skipping to the second part, and the second part is with the disclusion. So with the open mouth of the patient. MRI may be also indicated to when diagnosis of internal derangement is in doubt, and as a preoperative assessment before disc surgery. Sometimes it is useful in a tumor staging, so evaluation of the size, and extent of all soft tissue tumors, including nodal involvement. So we can also examine our lymph nodes, involving all areas, in particular the salivary glands. So magnetic resonance is a little bit more helpful in a salivary glands imaging than CT or CBCT. Then the tongue and the floor of mouth, of course, the pharynx, larynx, the sinuses, and the orbit. Then we can use our MRI in implant assessment or implant planning, but it's not so popular as a CBCT nowadays. What are the advantages of the MRI? So the first and the most important advantage is the ionizing radiation is not used. So I will try to tell you couple of times more, maybe, that this is the most important advantage of ultrasound and MRI. Then no adverse effects have yet been demonstrated. So this is safe, recognized as a safe method. Image manipulation available, of course, as in the different other 3D methods. High-resolution images can be reconstructed in all planes using 3D volume techniques, so we can also provide a 3D reconstruction in our computer program. Then, excellent differentiation between different soft tissue is possible, and between normal and abnormal tissues, enabling useful differentiation between benign and malignant disease, which is really important, and between recurrence and post-operative effects. Then, useful in determining intramedullary spread. So this is really useful in our MRI, in our brain MRI examination. What are the disadvantages? So the bone does not give any signal in MRI. A signal is only obtainable from the bone marrow, which is of course inside the bone, although this is of less importance now that radiologists are used to looking at MRI images. Of course, our teeth will not be visible, as I told you before, but the inside part of our teeth will be a little bit more visible than the hard tissue structures, so the cementum and dentin and enamel. Then, next disadvantage is that scanning time can be long and is thus demanding on the patient. Then, it is contraindicated in patients with certain types of surgical clips, most old types surgical clips, cardiac pacemakers, cochlear implants, and in the first trimester of a pregnancy. But the MRI itself is considered as safe for the pregnant women. Okay, equipment tends to be claustrophobic and noisy, and this is true, especially the noise about this note about noise. Of course, the patient has headphones on their ears, but it is really noisy as a big party, techno party. Then metallic objects, for example, endotracheal tubes, need to be replaced by non-ferromagnetic alternatives. And of course, the whole equipment of magnetic resonance machine is very expensive. The very powerful magnet can pose problems with sighting of equipment, although magnet shielding is now becoming more sophisticated. And of course, again, bone structures, so bone, teeth, air, of course, and any metallic objects all appear black, making differentiation difficult. So air can look the same as bone. Okay, so this is our axial view of the MRI, one of the layers. As you can see, our teeth are not so clearly visible, but for example, muscles like our tongue is quite good visible. This is probably T1 image, I guess, because in T2, as you remember, our fluid would be a little bit more shiny, so hyper intense. And here we have some spaces. So in this particular image, you can see the infratemporal fossa, which is pointed on the left side of the image. Then, in the middle of our patient, we have mucosal pharyngeal space. So here we have our pharynx. Then masticator space on the right side of the patient. Here we have the parapharyngeal space called lateral pharyngeal space. Then we have our retropharyngeal space, which is really important for diagnostic. They have to mostly radiologists have to look at this space because it can be really tricky. Then we have our parotid gland space. Then dendral space again here, carotid space, of course, perivertebral space here, and this is paraspinal part of vertebral space. Okay, another example of the old image of the patient, MRI image. You can see that this is, of course, the sagittal view. And we can describe, of course, the sinuses if there is any possibility that the inside of the sinus we have some pathologic areas. Nasal cavity is not the best visible in here. As you can see, the nasal cavity is full of the air. And it is not recognizable as we want it to. Then we have the hard palate, soft palate, and oral cavity, and the tongue itself. Here we have, of course, the bony structures and our teeth. You have to imagine that here we have our teeth. Here we have our nasopharyngeal airspace. So trachea will be here probably. Here we have the part of esophagus, and etc. and etc. Okay, a little bit more visible atrial view. So this is more detailed and in a better condition. Here we have the patient nasal septum, which is, of course, hypointense structure here. Of course, sinuses. So this is our maxillary sinus on the left side of the patient. This is of the right side of the patient. Middle nasal concha of the left side of the patient. This is the area of our muscles, so temporalis muscles, muscle left side, right side. Here we have the lateral pterygoid muscle here. Here we have the ramus mandible or the condyle here. Here we have, of course, the external airy structure here. Here we have the part of the brain. So medulla oblongata, cerebral tonsil will be visible, both sides, cerebral hemisphere. Here we have the cisterna magna, of course. The mastoid ulcers will be quite good visible, but not in this imaging. So this is probably T1. The mastoid ulcers will be a little bit more visible in T2, a weighted image. Okay, next we are a little bit higher in the patient. Here we have again middle nasal concha. Here we have the nasolacrimal duct, both sides, of course. Sphenoid sinus is quite good visible here as a hyperintense area. What more? Basilar artery would be visible. Internal carotid artery as well. A temporal lobe in here, and more structures. I think that you don't have to know all of the structures on the MRI, just to know where we are. Okay, so let's skip. This is, of course, the MRI of the brain, so you can see that we are a little bit higher than before. Here we have the frontal bone, which is not so good visible. Here we have, of course, our skin and fat tissue before the frontal bone. Frontal sinus, this is really hard to differentiate those structures. So when the frontal sinus begins, this is really difficult to provide those information. Here we have the frontal lobe of the brain, of course. Here we have the occipital lobe. So this is quite difficult for us as a dentist to obtain or to describe our brains. And I hope that you will not be forced to do it in your practice. Okay, this is the look of the normal brain. We have to believe in this. This is the normal view of our chest. So we can see the heart here. The lungs, of course. This is again normal brain. Left side, right side. Again, normal brain in different images. Again, sagittal view of normal brain. T2 for sure, because our medullary fluid is, the cerebral fluid is visible as a bright signal. Okay. Another example, another image showing what we can image and what we can examine in the MRI. So, of course, the brain, so the head and neck area, then the chest, tummy area, of course, we can visualize the bladder area, kidneys, of course, the spinal cord mostly, and sometimes we can use the magnetic resonance for examination of the patient's different joints. So, for example, the knee joint. Okay, here we have the example of the magnetic resonance, which is showing our circle of Willis. So MRI at the level of the circle of Willis, of course, with the contrast enhancement. Again, different examples. Here we have different structures of the orbit. In the MRI, we can see, of course, our optic nerve, number 3 here. Here we have some muscles around the optic nerve. And again, here, number 3 is optic nerve. Okay, here we have the pathologic image. So this is not the normal tumor. Of course, we can see the asymmetric lesion, which is laying, of course, only on one side of the patient's brain. And we have here the hyperintense signal of the malignant tumor. Here we have the osteomyelitis. Here we have, of course, the CBCT or CT, probably. But in our MRI view, it is more visible that inside the bone is something going wrong. Salivary gland malignancy, of course, we can see that something's going on in here. So this is really important to look at the both sides. If we can see that there is a little bit of asymmetry or something is showing up only on the one side, we have to think about it as something pathological. We can, of course, visualize the parapharyngeal malignancy. Here we have Okay, then trauma of the eyeball. You can see that the internal structure of the eyeball is not as we've seen a couple of slides before. So probably the inside of our orbit is hemangioma or something like that. Okay, this is the liver, and we can see that there are some cropped areas, and this is called multiple fungal abscesses. Here. So abscesses are hyper-intense in here. Liver cirrhosis, so this is the one of the main pathologics of the liver. Okay, let's skip to ultrasound examination. This is, of course, the typical ultrasound equipment. And in physics, let's start with physics. In physics, the term ultrasound applies to all acoustic energy, so both longitudinal and mechanical wave with a frequency above the audible range of human hearing. So we cannot hear those sounds. The audible range of sounds is 20 hertz up to 20 kilohertz. And of course, the ultrasound is frequency greater than 20 kilohertz. So here we have the graph showing our infrasound. This is the our range of hearing, so human hearing, and the ultrasound only some dolphins can hear the ultrasound waves. Diagnostic ultrasound is now established as the first choice imaging modality for soft tissue investigations of the face and neck, particularly of the salivary glands. It is, of course, a non-invasive investigation that uses a very high-frequency pulsed ultrasound beam. The frequency is from 7.5 up to 20 megahertz. Rather than ionizing radiation. So this is another method that we are not using our radiation. And we are using those high-frequency pulsed ultrasound beam to produce high-resolution images of more superficial structures. The use of color-powered Doppler allows blood flow to be detected. So the Doppler method is a more advanced method of ultrasound examination, and most of the newest machines, ultrasound machines, have a Doppler power option. Okay, this is the room of our department of radiology, so you can remember that room. And we will talk about a little bit about equipment and theory of the ultrasound examination. So here we have, of course, several machines that are available. And here we have the main machine. Here we have the bed for the patient. So the patient during the head and neck ultrasound examination has to be laid down. This is more comfortable for operator, of course. This is the computer screen. Those are many cables that are connected with the computer. Here we have our probes and more different equipment. So the high-frequency ultrasound beam is directed into the body from a transducer placed in a contact with the skin. We need a jelly to provide those images. So the jelly is placed between the transducer and the skin to avoid an air interface. As the ultrasound travels through the body, some of it is reflected back by the tissue interfaces to produce echoes, which are picked up by the same transducer and converted into an electrical signal and then into real-time black, white, and sometimes gray visual echo picture, which is displayed on our computer screen. Here we have our jelly, which is used in every single ultrasound examination. Then here we have the different probes. So this is the probe, the biggest probe used in the head and neck examination. We can use this kind of probe to visualize the neck area, so mostly trachea region, etc. Here we have some intraoral probes here, and nowadays the newest equipment involves sometimes the probe finger probes to provide the intraoral examination more comfortable for the patient. And here we have a picture, an example of the patient undergoing of US examination. And here we have the submandibular gland, salivary gland. Here we have the area. And of course, those colorful pictures are made with the use of color Doppler. So in a color Doppler, we can see the blood flow going through the different veins or arteries. And the most thing for you to remember is that the red color is not always the artery, and of course the blue color is not always the vein. Those different colors are made to differentiate the blood flow. So the red colors mean that our blood flows into the probe, in the direction into the probe, and the blue color means that our blood flows directly opposite from the probe. The ultrasound image is also a sectional image or tomograph, but it represents a topographical map of the depth of tissue interfaces, just like a sonar picture of the seabed. The thickness of the section is determined by the width of the ultrasound beam. Areas of different density in the black-white echo picture are described as hypoechoic or hyperechoic. It means light areas. So in the ultrasound, we don't use the intensivity of the signal, but we can describe the different areas of the picture as a hypoechoic, isoechoic, or sometimes hyperechoic areas. Utilization of Doppler effect is a change in the frequency of sound reflected from a moving source allows the detection of arterial and venous blood flow. As can be seen, the computer adds the appropriate color, red or blue, or something between red or blue, to the vascular structures in the visual echo pictures image, making differentiation between structures straightforward. The ultrasound wave must be able to travel through the tissue to return to the transducer. If it is absorbed by the tissue, not image will result. Air, bone, and calcified materials reflect all the ultrasound beam. Only their surfaces are visible. Ultrasound is not able to penetrate intact cortex. This is useless for imaging of bones or other bony structures. Okay, one more thing about Doppler method. So the Doppler is based on registration of change of frequency of sound waves reflected of a moving object, so-called Doppler phenomenon. In medicine, it is the blood which is a moving object in blood vessels. Blood cells incoming toward the probe reflect the acoustic wave, thus increasing its frequency. Sorry. On the contrary, in case of blood moving away from the probe, the frequency of the wave returning to the probe is decreasing. In those both cases, the difference between wave frequency emitted by the probe and frequency of the wave returning to the transducer is proportional to velocity of the moving object, and this way to blood velocity. Okay, so we have different options in our Doppler examination. We have a continuous wave Doppler, is examination of velocity of blood flow in large blood vessels without possibility of their identification. Pulsed wave Doppler, this is the examination of blood flow in a selected blood vessel within limits set by measurement error when blood velocity is too high. Color Doppler, Doppler examination coded with, for example, color. So blood flowing towards the probe is presented as a red on the screen, and blood flowing away from the probe is blue, as I told you before. Power Doppler is an examination with enhancement of power of incoming signal allows visualization of small blood vessels with low blood flow, which can be hard to identify in other different methods, but without information on the direction of a blood flow. And we have a duplex or sometimes triplex Doppler. This is the combination of B mode on the Doppler basic mode and the Doppler ultrasound, and enables imaging of a blood vessel, adjustment of Doppler gate direction of blood vessel test, increasing precision of signal measurements. And here we have another example of our colored Doppler. This is the ultrasound examination of our tongue. And here we have some blood vessels. We cannot describe that they are arteries or vessels. Of course, as we know, there's a different types veins and arteries in our internal structure of our tongue. But here we have the different colors describing, of course, the blood flow direction. Again, power Doppler here. Triplex Doppler. You can see that this is the more advanced method. We can track the blood flow, the intensity. Okay, we have a tissue harmonic imaging as well. So in this mode, a deep penetrating fundamental frequency is emitted into the body and the harmonic overtone is detected. This way, noise and artifacts due to reverberation and aberration are greatly reduced. Sometimes we can use the elastography, the technique used to assess stiffness of examined tissue. And we can see the different colors describing our stiffness of the structure. So the high stiffness will be marked as a red color, and low stiffness will be marked as a blue color. Okay, what contrast media or contrast agents we can use in ultrasound? So mostly in most ultrasound examination, only gas bubbles will be needed. So gas bubbles and shells can be, of course, contrast agents. Then microbubble shell like albumin, galactose, lipid, or polymers. Then shell materials influences microbubble residence time in blood vessels. The more elastic the material, the more acoustic energy it can withstand before bursting. Microbubble can score like airy, heavy gases, like perfluorocarbon or nitrogen. Heavy gases are less water soluble, so they are less likely to leak out from the microbubble, leading to microbubble dissolution. As a result, microbubbles with heavy gas cores last longer in circulation of the body. Regardless of the shell or gas core composition, microbubble size is fairly uniform. They lie within a range of 1 up to 4 micrometers in diameter, so they are really small. That makes them smaller than erythrocytes, which allows them to flow easily through the circulation as well as the microcirculation. Sometimes we can use the saliva of the patient as a contrast media as well. So this is the contrast enhanced lymph node here. And some maybe few words about patient preparation. So patient referred for an ultrasound scan of salivary glands, for example, or head and neck soft tissue does not require specific preparation. The examination is performed in a patient lying supine with head tilted backwards, as well as away from the probe. A small cushion can be placed under patient's back. Sometimes it is possible to carry out the examination in a patient who is seated in a specific situation. This is the ultrasound of the thyroid, so you can see that the position of the patient is really specific. And of course, our head have to be moved like backward. This is our thyroid gland. This is normal thyroid image. And what are the main indications for ultrasound in head and neck? So the evaluation of swellings of the neck, particularly those involving thyroid cervical lymph nodes, which are not healing above 2 weeks, or the major salivary glands. Ultrasound is not regarded as the investigation of choice for detecting solid and cystic soft tissue masses. Detection of salivary gland and duct calculi, determination of the relationship of vascular structures and vascularity of masses with the addition of color flow Doppler imaging. Assessment of blood flow in the carotids and the carotid body tumors. Assessment of the ventricular system in babies by imaging through the open fontanelles can be really helpful and safest method. Therapeutically, in conjunction with the lithotripter, to break up salivary calculi into approximately 2 millimeter fragments, which can be then passed out of the ductal system. So we are avoiding the major surgery for the patient. And the ultrasound-guided fine needle aspiration biopsy can be used, of course. Okay. Some words about ultrasound jelly or gel. Must be applied during ultrasound scan in order to eliminate the bubbles of air from between the probe and a patient's skin. Otherwise, ultrasound beam would bounce back from skin-air interface and the examination would not be possible. In examination of the superficial structures such as maxillofacial soft tissue, a special ultrasound gel pad or acoustic coupler can be used. It prevents from near-field artifacts. Patient can also be asked to fill the oral cavity with water in order to create a certain water distance. Okay. Advantages over conventional radiography. So sound waves are not ionizing radiation, therefore examination is safe. In humans, there are no known harmful effects on any tissues at energies and doses currently used in diagnostic ultrasound. good differentiation between soft tissue, widely available, inexpensive, real-time imaging, and the radiologist present during the investigation, the whole investigation. But we have a few more disadvantages. So, limited use bones, of course, a very operator-dependent technique. So, the radiologist has to be really advanced in the ultrasound examination to provide a good examination. Image is difficult to interpret for unexperienced operators because image resolution is often poor, and especially on printers. Okay, so thank you for your attention for the first part of the lecture. We will take a 5 minutes break, so let's meet, maybe 8 minutes break. So let's meet 5 past 9.